to the Doctor's Corner with Dr. Kline and Janelle Elgaway. And now, Janelle Elgaway and Dr. Kline.
Good evening. Welcome to the Doctor's Corner on Call 360 Network. I'm your host, Janelle Elgaway, and we are here with co-host Dr. Kline. Welcome, Dr. Kline.
Good evening.
If anyone would like to call in with a question or comment this evening, you can do so at 415-915-2291. We will also answer a few questions from our mailbag. If you have future questions you would like to ask Dr. Kline from the mailbag, you could send them to my assistant, Jess Stewart. Her email is jstewart, JSTEWART, at caw360.com. There are two ways to listen to tonight's show: through our website, which is www.cawnation, or YouTube channel and search The Doctor's Corner. So, Dr. Kline, is there anything newsworthy that occurred in the last week that you would like to share with us?
It appears that some prosecutions may be started against doctors who, without medical reason, take people forcibly off their medication regimens for pain. A physician I'm familiar with in Montana prescribed some methadone for a patient for his pain, very good pain medicine. And the man took it for a month and worked quite nicely. And the next prescription he got, he swallowed the entire bottle. So the doctor's patient was dead. The doctor had no idea he was suicidal. The doctor was convicted of manslaughter and is getting ready to serve a prison term. But a doctor who cuts somebody off their medicine knowingly and then watches while the person screams for help and says, I'm going to kill myself, that doctor is not prosecuted. So the prosecutors are starting to catch on that if doctors take somebody off their medicine for no reason and can't really substantiate a medical reason, like a side effect or something, they just do it because the government has suggested they do it. Hey, prosecutors are starting to look at that. So that's the news of the week.
Okay. Well, let's take a few questions from our mailbag this evening. First question is, for the blood sugar test, drinking a sweet orange liquid, and then an hour later, this woman, she wanted to know, she tested her blood sugar again. What are the normal blood sugar levels after the specific test for diabetes?
It depends on your age group. That's something the diabetic community has not really addressed. They think that a blood sugar of 125 is normal, 126 is abnormal. And actually, when they did studies in older people, blood sugars after drinking this cola, which supposedly is only supposed to go up to 140 or 160. For most people, the normal is 200, and for older folks, it's 260. So that means basically that blood sugars that occur in your body of 200 are within normal parameters, or if you're older, 260. Now, people try to draw a lot of conclusions from, it only went this high and this high. This is the pseudo-science of blood sugar control. As we've discussed before, there's no evidence except for one unreplicated study that shows that there's any shred of evidence that controlling the blood sugar controls the complications. So then it gets carried into even more ridiculous areas, like, your blood sugar went to 200 after you drank the cola, so you're doomed. Now, of course, you need to donate money to us so that we can do more research and save you. But that's not true. So don't worry about your blood sugar after you eat, even if it's 300. If it's 300, then you go to the eye doctor and get your diabetes confirmed by looking in the back of your eye. That's like looking at your body under a microscope. The blood sugar is a symptom of diabetes. It is not diabetes. So,
Dr. Kline, someone wanted to know if palliative care is for people that have more than 6 months to live.
no, that is incorrect. That palliative care applies to anyone with any illness that you cannot cure, and the person has symptoms that need to be treated to improve the quality of life. A person with cancer who's being treated with IV medicines that's making them sick and vomiting all the time is palliative care. Even though the medicine is being used to control the cancer, it is not a cure. Then the person has vomiting. That should be treated. That person has palliative care. Now, what happens if the person gets a cure? Then they're no longer palliative care. So palliative care is very simple. Disease you cannot treat directly, and symptoms that are ruining your daily life. That is a palliative care patient, period. Nothing else. That's the United Nations definition. It's the definition of NIH. It's the definition of lots of different sources. And you can go to my website, which is free. I'm not selling jellies and jams, but it is a place to get information at thomasklinemd, all jammed together, .com. And it'll take you to some articles with references on palliative care. And you can judge for yourself. Read the articles and judge for yourself. This is funny, really, to me, because it's real simple. Hospice care, or having 6 months to live, is a subdivision of palliative care. And so a lot of people are confused. But when you tell them what the story is, they think, oh, I don't know. What is all that about? Bans, fear of addiction, phobia. Nobody wants to come up with some kind of definition that's going to excuse people from the CDC with guidelines that want everybody off pain meds. That's my take. It was also, when they first came out, I've got 6 newspapers within one day that said CDC warning of epidemic. And you need to do something about it. You know, like, let's control all these prescriptions doctors are writing. So I do tend to go on and on. So.
All right. Well, let's get into tonight's program. I'd like to introduce our guest, Grant. Grant, welcome to the Doctor's Corner. How are you this evening?
Well, thank you for having me.
We're happy to have you. Grant is a pharmacist. Let's start off with what is a PA and what is a prior authorization?
Prior authorization is an insurance or paying entity's privilege to deny use of a medication without exceptional proof from a physician that the medication is needed.
So in the old days, this was unusual medicines in the old days, like 5-6 years ago. Why were PAs requested? Were they unusual?
10 years ago, they were unusual. 5 to 7 years ago, different insurance companies began using this tool as a method to deter physicians from writing particular medications that cost more than the insurance company chose to pay. So a physician would have to go to extraordinary steps to prove that this was the medication that was best to treat this patient.
So you're seeing more of these?
It's multiple per day now. It
so
is not unusual to.
How many a day would you? Okay. How many a day would you see, say, 10 years ago?
Between 5 to 10% of the total prescriptions written now.
How many? Oh, and now it's almost 1 in 10.
Yes, wow. Nearly 1 in 10.
And what was it 10 years ago for comparison?
1/2 of 1%.
Wow.
I think you'd see about 1 every 200 prescriptions.
Okay, and I guess as a physician, I'm a little irritated because the drug company sends a notice to the patients. Your doctor did not fill out paperwork, so we cannot give you your medicine. So we become de facto employees of the insurance company. And how about on your end? What do you have to do? Is this more time on your part?
I have to process each claim, each prescription to an insurance company to be told, or by Medicaid or by Medicare, that this particular medication requires a prior authorization process. There is now a company who is linking with most of the pharmacy software programs that are available so that we can send an automatic set of paperwork to the physician as long as the physician is enrolled with this particular company. So you know which paperwork each individual insurance company wants, and at least the physician doesn't have to spend another 10 minutes just trying to find out what needs to be done. It's a nightmare, in my opinion.
So this is another cottage industry, which is taking all the PAs and running them together. Is this Cover My Meds?
Cover My Meds. That's exactly it.
Okay, so I get these in the mail, and they want all on the web, and
email,
I'm ready.
Or fax. You'll get them multiple ways, I feel sure.
And interestingly, about 20 years ago, they did a study at Aetna to find out whether getting prior authorizations for medical procedures really made a difference. And guess what? It did not. It wasn't worth the money because most all of the requests for prior authorization were granted. It's very hard to deny something like an operation. Now, the drug companies don't very often deny. I find when I fill these things out and spend 15 or 20 minutes. That's the time I can see one patient. They generally are always approved. But lately I'm getting some new twists. One night they said, oh, you can't fill out all the information here on the web. We're going to have to send you a fax to fill out the next day. Never came. Never showed up. And some of them are saying I have to call people. So I get on the phone and I call these numbers and I get hold of people that don't know what's going on. And they claim they're medical directors, which is a real fib because when I talked to them, you could tell they weren't medical directors at all. They didn't know what was going on. So is it the benefit managers that are behind this, Grant, or who's behind this? Okay.
The PBM. The pharmacy benefit manager for whichever organization that they're serving is attempting to put up a roadblock, in my opinion, in hopes the physician will not want to go through the steps to get this medication approved.
Yeah, and then they blame the doctor and tell the patients, hey, your doctor isn't being cooperative. I'm very sorry. Goodbye. What if, just as a hypothesis, what if doctors started to charge $50 per PA to the patients? Basically, we've always had the stance that people and their insurance companies have a contract that does not involve the doctor. And if we threaten to charge, then a lot of patients would be calling up the benefit managers and saying, what's going on? I don't know if that ploy would work, but, people generally become incensed when they're charged money. And I can say, I'm sorry, I'm not part of the insurance company, They're asking me to do their work. I think that would flop.
The roadblock that I see with that, Doc, is I have a contract with Aetna. I have a contract with Blue Cross Blue Shield of Illinois, of North Carolina, of Alabama, of California. I have all these multiple contracts that state that I will oblige by this set of rules, and they update it weekly, monthly, sometimes annually, with all these statements saying that I will notify the physician and not fill this prescription other than as a cash prescription.
Okay.
I don't know how the physician's contracts with different hospital systems are set up, but most physicians are now aligned with a hospital system.
That's true. Yeah.
And how those hospital systems handle that, I don't know.
Well, President Trump actually mentioned the PBMs in a speech and said we need to get rid of them. So that's kind of nice. I know that lobbyists are working on it. Lobbyists for independent pharmacies are working on this. And what I found out in talking to the lobbyists, something I didn't know, the system for Medicaid to supply Medicaid patients with medicines does not involve a PBM. Is that correct, Grant?
It depends on the state that you are discussing.
Okay.
Some states have moved to pure insurance companies to administer their programs.
Mm-hmm.
I don't know any. I can't sit here and pull out states to say this happens or that happens. But Humana runs some states' Medicaid programs. And so they have prior authorizations that are established by the state and Humana in conjunction with one another, and Humana administers those prior authorization programs.
Uh-huh.
United Healthcare has some programs. Aetna has some states. I know South Carolina has about 4 different insurance companies that are all bidding for the business in South Carolina. And so South Carolina Pharmacy is just, they're getting clobbered. They're making less than $1 per prescription, no matter what the cost of the prescription is, to fill prescriptions now, because the different insurance companies who are administering the plans are pushing reimbursements down in order to win the business of the state.
Well, see, we're saving you money. Yeah. So then you just don't fill the prescriptions. Look at the money you can save. Look at the money you could save if you didn't fill any prescriptions. You know, I mean.
What criteria do insurance plans use to deny prescription payments?
I can't follow that question directly, but I'm going to take it from my perspective.
Okay.
They don't attempt to deny specific prescriptions, but they will deny a portion of a class of drugs, blood pressure medications. There's 12 to 15 different, what I'll call ACE inhibitors on the market. They'll choose 3 that they will cover, and the others just go by the wayside. So they're limiting access to the entire breadth of medications that are available by saying, well, all of these work the same way. All of these have the same typical outcomes. These are the 3 we're going to allow the physicians to write.
Can an insurance company get away with, we did not deny the drug, just the payment for the drug?
No. If they set up the drug that they're going to choose, that physician and that particular insurance group will have to write for that medication, and they will reimburse for that medication. I think we're thinking differently. I don't think I'm answering your questions.
No, you are.
With the view that you're speaking.
No, we wanted to hear it from the pharmacist's viewpoint, so that's what we're. So keep on. You're doing fine. So what you're saying, this is a broad way to supposedly control costs, but behind the scenes, lots of other things go on, like secret contracts, which I understand you guys have to say that you're not going to tell anybody how much they're paying you, and blah blah blah. And I heard that that's being eliminated. Is that true, Grant? This secrecy clause when you sign contracts?
I don't think it's being done away with. I still think the pharmacy business managers are backdooring and finagling as much as they possibly can. And we're in the process right now that CVS is currently working toward a closing of the deal to buy Aetna. Uh-huh. So now CVS owns the drugstore.
Mm-hmm.
They own the insurance company. They also own the PBM. So all they're doing is moving monies from one place to another, creating losses in one place, creating gains in another, wiping out the taxes because you've got a loss on this side and a gain on the other side. I think they're printing their own money.
You know, we've got a lot of activists here. You know, there's 3% of the population is on long-term pain medicine, and of those, almost 70% are being tapered off. 40% of those, which is 4 million people, have been taken off completely. But they have families and friends. So if they have 3 friends, you've got now 10% of the U.S. population involved with the tragedy of the pain refugees. And when I lived in California, Cesar Chavez, a union organizer, said to all of us in California, boycott lettuce, because these people are not paying us a decent wage and they're selling water to us. The farmers in California sold water to the people working in their fields. So everybody stopped buying lettuce. And you know what? It worked. So maybe we can get people to boycott CVS. Boycotts do work. And
they absolutely do.
And, you know, one of my Twitter polls, I asked people if they were having problems with pharmacies, and I said chain pharmacies. Yes, 40%. 40% of people are having problems with chain pharmacies. Guess how many for independent pharmacies like yours? 1%. So anyway, on my Twitter, I'm going to suggest that people start boycotting CVS. I personally do. I've stopped going in the building. And I try to encourage my friends and family, and they're all for it. You know, they'll say, hey, there's plenty of other pharmacies. And I said, well, find yourself an independent pharmacy, and if you want to buy liquor or something, go to a liquor store, you know, or a supermarket. You can buy everything in a supermarket that you can buy in a CVS. I have talked on the side to other pharmacists who have worked both retail pharmacies for large corporations like CVS and independent pharmacies like yours, not necessarily little, but independent pharmacies. And the stories I hear really need to be told of the high numbers of prescriptions that are not filled the same day because they got some little inventory thing going where they don't stock enough. You know, arbitrary denials. We heard stories that people with ponytails and tattoos in CVS were deemed suspicious. So I think, you know, it'd be nice to have some inside information from pharmacists who would like to talk to me, off the record, so that if we ask people to boycott large pharmacies, we'll have a reason for it. You know, Cesar Chavez says, you know, what kind of people are these that charge water for people to get a drink of water when they're working out in the fields in 100-degree weather? You know, I mean, that kind of egregious stuff. So we need some examples from pharmacists. Maybe some are listening who can contact me or Janelle confidentially, and then we can put together a little package and ask people to start boycotting CVS. You know, I mean, there's 26,000 people on my Twitter feed, and that's a start.
That's actually a significant start.
And 10% of people, you know, I mean, politicians ignore the pain population, but I mean, really, 3% plus another 3 to 4%, that's 7%, you know, that can throw elections. And you know what? You get somebody on your side in a pain community with all this tragedy going on with the great, sweeping pain refugee crisis, 10 times larger, by the way, than the opioid crisis, 10 times larger. And these folks are, you know, they've had it, and they want to do something. Tell me what to do. So we won't boycott your pharmacy, Grant, I promise.
That's one way or the other. It's people generally, I don't think, understand pain. Physicians, somewhat included. Pharmacists don't understand pain. It is not a thrust that we get in pharmacy school. Yes, we understand the physical characteristics and the chemical characteristics of the drugs, and we know the receptor sites and why one particular product may adhere faster or more thoroughly than another product and work for a longer time period. But as far as the psychological management of pain, pharmacists know nothing. And I wish I could say we did. I've been able to, for many years, talk and listen and hear people discuss and how it's affecting them and how it's affecting their lives. But on a one-on-one basis, and to apply that to the population, it's not something I've been trained. I wish I could say it was.
Well, that's interesting because doctors are in the same boat. Go ahead, Janelle.
Yeah, if that's going on, how can a pharmacist deny somebody walking in the door then? If a doctor has written a legitimate prescription to them, how can a pharmacist deny them?
They can't.
Well, they are.
The only thing that they can do is, and we are now duty bound to, in most states, and I can't say that it's every state, but just about every state now has a prescription drug monitoring program of some type, or PDP, or some type of online system that when I got my permit for the store, I was required that I personally be the key person for our entity to look up every patient and ensure that they are not getting medications from more than one site, more than one physician, and according to the way the prescriptions are written, not over-consuming. So if they have a 120-tablet prescription to be dosed 4 times per day, my personal standard is the 90% rule. I can fill it after 28 days, the next prescription, as long as the next prescription is not written for a higher dose. I cannot refill that prescription or fill the next prescription. That's the only time you can do it.
But what about, we've heard stories of pharmacists where somebody just comes in with a prescription from the doctor and says, I'm not filling this. If so, I mean, they'll say that even before they appear to be checking the computers. You know? I mean, they've been profiled at CVS.
That just makes no sense to me. That is not any attempt to provide care. So I don't know what that pharmacist is doing, what pharmacist had been subjected to what previous knowledge they have of said patient, but that's silly.
Well, we've actually run, in other words, I have a prerogative if somebody comes to me and says, I want to be your patient, and I say, I'm declining. But once I take a patient on, then we have a contract that I take care of them. So we're hearing that pharmacies who enter into a contract with a patient and start filling their prescriptions, all of a sudden, 3 months later, will say, hey, we're uncomfortable with this. We're not going to fill it. To me, that's an unethical breach of contract, of a professional contract, because they agreed to take on the patient, and this is for no reason, obviously. The PDMP research doesn't show any problems, and to me, that's pretty unethical. It's perfectly okay to say, I'm uncomfortable with this prescription. Let me call your doctor and talk it over.
Well, the doctor discuss it, document what you needed to document, and take care of the patient.
But, the Board of Pharmacy, is the Board of Pharmacy helpful here in North Carolina on these issues? Is it worth talking to them?
You can talk to them. I can talk to them.
Okay, and they'll listen.
But the gentleman from the Board of Pharmacy who does my site inspections has come in, has looked through records before, and said, "Oh, you have prescriptions from such and such a doctor." And I say, "Well, yes, I do have some prescriptions from Dr. X." There's nothing at the Board of Medical Examiners with any derogatory information about this physician at all. He's a licensed anesthesiologist. He works at a hospital in Greensboro, and he aids in management of pain patients. He's very thorough. He gives very dense information on each and every prescription, that he's done a multi-state check, that he's following up with these patients. As long as he doesn't write exorbitant amounts of medications, he writes within semi-standard quantities of medications. He's not writing for 680 tablets of something. He's writing for 118, 140, and 90 tablets. He's writing for amounts within a standard that anybody would use. What's the question?
And the other interesting,
as long as I know.
Yeah, the other interesting thing is that when a pharmacist, for example, this happened to me, the pharmacist, after filling several prescriptions, suddenly announced in front of everybody in the pharmacy, "We're not filling any more of Dr. Kline's prescriptions." The reason was not valid because the pharmacy owner reversed it. But that's an interesting legal problem. If a pharmacist denies a prescription without talking to the doctor, that's an accusation of negligence.
An accusation of negligence,
yeah,
and something that should be substantiated. And if the pharmacist chooses to not fill a prescription, that's the pharmacist. He has that privilege. He needs to explain why. And I would like for him to say, or her to say, "I'm not comfortable because of whatever reason."
And I've called the doctor. Should that be included?
I've called the doctor. I've gone through my ideas. These are the things that make me hesitant.
Mm-hmm.
I've also checked with whatever pharmacy up the street, and they have a supply to carry you for enough hours until they can either get it ordered, or they have a supply to keep you for the month, or whatever supply they need. They need to be honest with the patient and say, this is my concern, and for this reason, I've taken the steps to establish another pharmacy who can provide this service for you.
How about individual pharmacists? We do have a copy of a memo at one of the chains that says if people are having problems with a pharmacist denying prescriptions, to speak to the pharmacy manager. In other words, if a pharmacist feels uncomfortable, does that mean that the entire pharmacy should feel uncomfortable, other pharmacists, and especially the manager? So is that a possible way that people can ask, say, okay, I understand you have these concerns, but can we kind of appeal this to the pharmacy owner or pharmacy manager? What do you think?
How do you know it's not the pharmacy manager that's in that position, taking that initial position?
Yeah, well, so, if the guy says it's a pharmacy manager,
very difficult. Yeah. That's a very difficult thing to look at and approach. Personally, if you've run into that pharmacist is not going to change their view. Mm-hmm. And it's just time to turn and walk.
Yeah. But, then you're labeled as a drug seeker. And so then you find that there's no pharmacy in the country that will see you because it goes on the computers.
I don't know how that's going to happen.
Okay.
How have you heard of that actually happening?
We've had people reporting they were profiled, but I'll have to admit it wasn't from the pharmacy. It was doctors putting stuff in their charts, their electronic medical record, that they were drug seekers, and then it kind of hit all the hit all the computers. So and I guess we need to ask
in the hospital system.
Yeah, if you yourself, you get a prescription you're uncomfortable with, you call the doctor and you work it out and you say to the patient, I can't do this. Do you do anything on the computer? Do you enter any of that information into the computer that you decline to fill?
Absolutely not.
Okay, good. All right. So if people are being profiled, it's not from the pharmacist, yeah.
I don't think any independent pharmacy has the ability to put anything on a patient record that could be seen at any other pharmacy.
Okay.
But Walgreens has what's termed a cellular system. They'll have 15 to 30, maybe, I don't know how many numbers of pharmacies, that every message on each patient within that cellular area, Columbia, South Carolina, St. Louis, Missouri, will be cells. And if somebody puts a note on a particular patient profile, every pharmacist will see it. And then every pharmacist will have to stop and say, okay, who wrote this? How trustworthy how do I feel about the pharmacist who wrote this? How do I feel about this statement itself? And then move forward. But I think CVS has the same type system. I think CVS, you can see everything that everybody writes anywhere in the nation on a patient.
But now,
don't tell me that. It's been a long time since I've worked for CVS.
Okay. So pharmacists can put notes into the record, the patient's record. You keep a separate patient record that you pull up like we doctors do, right?
Correct.
So you can put your own private notes in there that you want, like we as doctors can put private notes in.
Correct.
But you're saying it doesn't hit the wires unless you've got CVS or whoever, allowing people to peer into it. Switching subjects a little, what do you think about the police being able to peer into pharmacy records of individuals without a warrant?
I think it's as bad as it can be.
That's kind of police states, though, isn't it?
I'm gonna just throw the question out for you. I don't think, and I'm not certain, but I don't think anybody can peer into pharmacy records without my permission at my pharmacy. I don't think I have ever allowed access of any sort, be it board of pharmacy, medical board who comes in and asks us questions, the sheriff's department, anybody. If I don't have a subpoena or if I don't have I know this is reason to do this, they don't get anything because the HIPAA side's going to come back and get me. I don't care if it's law or not.
Right. But what about the PDMPs? In this state, the PDMP, the Prescription Drug Monitoring Program, the police have free access to.
There is a assigned individual, if I remember correctly, in Union County, North Carolina, who has access. And that person has been, according to my understanding of discussions with the sheriff's department, there is only one person who has unfettered access.
Okay.
And my understanding is that the sheriff has instructed that person, you don't just go around looking at people to try to create problems. I don't know that that's true, but I surely do hope that it's true.
We're checking into that. We got a report from one of the other states, and I forget which one it was. I think it might have been Massachusetts, that since they liberalized the law, the police inquiries into people's pharmacy records went from 6,000 to 14,000 per year.
Just because they could.
Just because they could. Now, each state is different. The DEA has access to any medical records they want, and that's a federal court decision. There's no way around that. But states, individual states, regulate who goes into the systems. And my understanding is they passed a law here in North Carolina which allows the police to get into the PDMP anytime they wish I'm going to ask for legislative review of that to see what is going on. The thing is that people are now being labeled as addicts if they're on methadone, and I use methadone a lot for pain. It's a great pain medicine. But if some police officer pulls up a record on a traffic stop and sees methadone, hey, guess what? You're labeled. You got an A around your neck. You're an addict. And that's a pretty scary thing. And I'm going to be personally pursuing that with my legislator in the General Assembly to find out what's going on, because a lot of this takes place behind the scenes. There are now drug units in the Department of Health and Human Services, not the Pharmacy Board. They're not even involved. Should be. And they have their own little secret unit, and I did talk to a senior person there, and he told me the same thing you mentioned, that people are not generally peering in, and he's sort of the monitor. So that's kind of nice. Also, it's interesting that when people are frightened, they will do anything. When a hurricane comes, they tell you to put plywood over your windows. And, most of the time that doesn't work. The plywood's torn off, and it can actually change the pressure inside the house and blow out the windows in the back, blah, blah, blah. So when people are frightened, they'll kind of do anything. So these PDMPs have been just very popular because they're going to catch doctor shoppers. And in North Carolina, doctor shopping is illegal. So initially, there were a few people caught. Some were hustlers selling the stuff. Some were addicts. And 60% are people with undertreated pain. So I asked this fellow, who's kind of the senior monitor, I said, okay, how many did you catch last year in North Carolina? Guess how many doctor shoppers they caught?
A handful.
5. This is a $1.5 million program, and that works out to about $250,000 per snatch. Don't know what's happened to these people. Addicts have a disease and should not be imprisoned. Hustlers need to be imprisoned. I mean, if they're getting forged prescriptions and selling them, as you know, a bottle of oxycodone's worth $1,000, $1,000. And so if they're catching those, that's fine. But the 60% who are doctor shoppers, what are they doing with them? I don't have any follow-up yet, but I'm going to ask for legislative follow-up. What happens when they nail them? So there are some issues with PDMPs, and I don't know what the Pharmacy Board's stance on it is. The problem is that all of these things are driven by the fear of addiction phobia. So everybody thinks, oh, good. Oh, you're doing something. Oh, that's going to save us. Limiting a prescription to 7 days is not going to work, because if you talk to addicts, they get their addiction triggered with the very first pill. And you know who just wrote about that in People magazine? Jamie Lee Curtis. And she is a classic, what we call type 2 heroin addict, manifested through genetic dysfunction in the receptors. And first pill, she said the most wonderful thing that ever happened to her. So that's something that pharmacists can help out with. There's no reason to hand over a prescription to somebody, an opioid prescription, and say, is this the first time you ever took this? Have you ever had an opiate before? You're not going to find many people. I think my numbers say about 1 per 1,000, but still, if doctors said to people, have you ever had an opiate before? Because
they all say
once, yes. They also usually always say yes, but if somebody says no, then you can say, all right, look, if you take one of these and you feel relaxed and your pain goes away, that's fine. But if you take one of these and you feel like you're going to the moon, let me know immediately. This may be an addiction starting. And they should be able to go see their doctors, but doctors don't know this, so they're not doing it. But this is the way to control. You're not going to stop addiction, not the type 2 brain addiction. You're not going to be able to stop it because it's genetic. But you can certainly nab it early and catch kids that you read about in the newspaper before they end up intensely seeking substance, which is our definition of type 2 addiction. And you say, and the kid can say, wow, I went to the moon. You say, okay, you got a problem. You've got a disease. It's like diagnosing diabetes. And here's how we're going to handle it. And kids, if they've only had 1 or 2 magic carpet rides, are going to say, yeah, I'd like to have more of that. But they aren't going to go looking for it if you catch them early enough. But if you don't catch them early, this is so intense. It's actually an ADR. It's actually an adverse drug response because it only occurs in 0.5% of the population. And it's been that way since 1920. So with those statistics, it's starting to look like, hey, even though doctors are prescribing too much, if that's true, it's not really creating more type 2 heroin addicts or opiate addicts. And there's such a simple way to teach kids in high school, like we do sex ed and stuff. It's time to teach opiate addiction ed. So when some kid goes to a party, and there's right now the parties are running LSD, oxycodone, Xanax kind of dried up, and always some oxycodones. And so the kids are trying all these different things, and the one kid in the corner who's just going to the moon is the one in danger. And it's just, so anyway, pharmacists, can, when they hand a prescription over, and it doesn't matter by age, people at risk are people who are Mormons and people who are Muslim, because there's a co-trigger with alcohol. So folks that don't drink alcohol and maybe have just gotten to age 31 and never had an opiate. And I've heard this story. It actually happened to a physician. He was in his 30s. He was never drank. And bingo, he had a magic carpet ride. And he started immediately looking for more. As one addict told me in Portland, Oregon, he says, honestly, doctor, I don't understand why everybody doesn't do this. It is so wonderful. But it's really an adverse drug response. And not everybody's going to do it. If you give 1,000 people opiates, 4 of them will trigger a ride to the moon. The others will not, and never will not, have this problem. So it's pretty unusual that it occurs. So, we're used to screening people for rare diseases all the time. So people say, well, it doesn't occur enough, hold it. This is a serious fatal disease. So anyway, my point with Pharmacist is no reason not to ask everybody, have you ever had a pain medicine before? And if the answer is no, then you say, well, come in here, I want to talk to you. It's rare, and it's real rare, but still it's noticeable. The problem with kids, they don't know that the magic carpet ride is something unusual. See, they think all the other kids are feeling that way because they're smoking weed, and going, whoa, wow, I feel great. And anybody can get high on weed or cocaine or amphetamines, but not everybody can get high on opiates. You've got to have the abnormal brain receptors. So I kind of went off a bit.
We're going to take a call.
And I'm going to throw a question out for you.
Sure.
Because you seem to be keyed in to that receptor to some degree. Has there been any research to attempt to identify the difference in that receptor from a traditional mu receptor that receives that opiate and lodges and says, hey, I don't care that I'm hurting, even though I'm hurting, as opposed to euphoria?
Yes.
Do we know a way to identify those patients?
Yep. What it is polygenetic, which means there's a lot of genes involved. Each gene doesn't make that much difference, but they're up to about 14 now. So if you've got 14 genes that are abnormal that are creating the receptors, there's something wrong with the receptor. Maybe the affinity is too great, but let's just say something is wrong. The genetic papers that I have are pretty convincing, and they're coming from multiple labs around the world where they are now identifying the polymorphisms, which means an abnormal gene Actually, it's A118G. There's even a name for it. And how they know this making an abnormal receptor, but they're not quite sure why they're getting such an exaggerated response. It really is like an ADR, like an adverse drug response. Those occur only in rare people, and this is only occurring. Type 1 addicts that...
In rare situations.
In rare situations. But the official numbers are that in heroin addicts, genes are playing 40 to 60%, responsible for 40 to 60% of the problem. I'm not quite sure how they determine that, but that's a pretty high percentage. The fact that the numbers of people by population have not increased really makes it sound genetic. So that and these research papers, I'm just going through them right now, and I got a headache because you try to read these genetic papers, these lab rats and stuff like that, but what I'm finding is they're consistent amongst labs around the world. And supposedly there are 2 companies that are going to come out with a commercial product based on this genetic research where they can analyze your genes, and it's going to be about 80% effective. There's definitely a strong family run of the type 2 addiction. Twin studies show they're very high numbers, so we know that it's running in families. But you're right, the details of the receptor are not quite yet known, but they're starting to use these PET scans. A PET scan is like a live MRI where you can actually watch things happen. They radionucleotide attach things to like white cells so you can actually see the activity of the white cells. And there's a little bit of that indicating they're getting some of these receptors lighting up. The other interesting thing is if you block the receptor with naloxone, that's it. The addiction stops. So that kind of suggests it's the receptor as well, because naloxone is a specific mu receptor blocker.
Correct.
So
that entire discussion
Yep.
that you just went through is very, very interesting, because that's going to be our key to attempt to try to determine who may or may not fall into this trap.
Yep.
But in the meantime, we've got to figure out how to maneuver around those who have fallen into the trap and keep patients able to get the care they need, to keep physicians able to provide care without being afraid.
Exactly. And it's fear of addiction phobia. Because when we say the word addiction, it's like I use it's like saying diabetes. Well, there's type 1 and type 2 diabetes are very different. So whenever we start talking about addiction, we have to say, oh, wait a minute, what are you talking about? Or he takes drugs. Oh, which drugs? If he's taking marijuana and cocaine, then he doesn't have the same addiction, permanent type, very serious addiction that opiate addicts have, because the type 1 addict can stop. They don't want to stop, but they can. They have no withdrawal. Kind of the basic I'm at right now definition of a receptor addict is if you have withdrawal symptoms. And so that includes opiates, nicotine, and some alcoholics, some alcohol users, not all, small percentage, because only a small percentage of alcoholics, like about 5%, actually go through the DTs. So that was a little signal to me that, whoa, that means probably there's receptor downgrading, or whatever they call it, when people start to withdraw from things that are tightly bound to the receptors. So it's just those three. Some alcoholics and nicotine and opiates that cause these withdrawals. So there's clearly two different addictions, and they need to be approached differently. For example, in type 1 addiction is very amenable to therapy. Type 2 addictions occur in anybody that's got the gene. Doctors, anybody. They don't start off with psychological problems. That's bunk. See, that's how it gets mixed up. Oh, you read that addicts have these psychological problems and, blah, blah, blah. They do in type 1 addiction, but they don't in type 2 addiction. There's a lot of people who are heroin addicts who work, hold down jobs, nobody knows, and they just kind of take care of the base level of opiates to satisfy their receptors. Don't quite understand why that happens and the details of the receptors, but from looking at it with a telescope, across the field, it's pretty obvious. If some guy tells you that, that you work, who works down at the phone company with you, that, do you know I was a heroin addict? The other thing is a lot of people maintain their opiate type 2 addiction with Vicodin. There was a doctor that wrote a book called Free Refills. And he got hooked on Vicodin, but he stayed on Vicodin. He lost his license, got it back, 5 years and blah, blah, blah. Interesting story in his book, Free Refills, Free Refills. Dr. Grinspoon, who works at the Mass General in Boston, where I was for a while. So there's lots of facts that we can present about addiction. The problem is this is new information. And people don't like new information, and they don't like changing their minds. So my thought is, and Janelle, we've been talking about this, is to have roundtables. Don't just have me telling the story. Have it presented at a roundtable with me and somebody who doesn't believe all the stuff I'm saying, and then have it moderated as like a learning session. This is how they did it in South Africa with Truth and Reconciliation. It's a great idea. And so, I think we could do that if people would organize it, and have these roundtables of pharmacists and maybe doctors and then some patients and a moderator and start looking at the data. And one thing I can say is that I do not have interest in anything else. I'm not paid by anybody. I don't get grants. I don't belong to organizations. I'm strictly interested in this from the standpoint of what's happening to an awful lot of patients for no reason. And I think we do need to do something. And then we also need to look at how to treat addiction. As you mentioned, Grant, we've got to take care of the people that have already fallen down the well.
Yes, we do. I find your thought of having some type of roundtable discussions very interesting. I've had a discussion recently with the University of North Carolina research in the nephrology department, and it's quite interesting, the stories that this person had to share about how pain management is being handled in the nephrology department at University of North Carolina.
Okay, hey, put them in contact with me. We need to get discussions started, and they can start locally. We don't need to have a big deal, just a bunch of people getting together. This is a slow process, and during the process, we can learn more about are we correct or not. The one thing that because I have a PhD also is that I'm a little bit more trained in research, how to analyze research and how to critically think in terms of the design and analysis of research, so that there's nothing that I say that I can't back up. Occasionally I'll have an opinion, and then I kind of raise my pinky finger and I say, this is my opinion. But everything that I've said tonight, I can back up. So that's part of the roundtable. People say, well, show me, and then I can, and then people can make up their own minds. Just because I say something doesn't mean that people need to follow it. But if they read my source, then they can decide themselves. And sometimes they'll point out to me that my source looked a little fluky, and that's okay, but that's the kind of dialogue that takes place in these roundtables. And having a university connection sounds wonderful, Grant, because we need people that, can ask serious and probing scientific questions, like you just did. Okay, Kline, this sounds wonderful, but what about this? And that's what I'm lacking, because I go on these shows and stuff, and we have a lot of pain patients and everything, but I need people to come at me, and say, hey, That sounds fluky, or how'd you justify that? So,
well, Dr. Kline and Grant, we're going to have to wrap up here. But did you both want to say any last words to our audience tonight?
Pharmacists have been an important part of medicine for a long time, and it's very sad for me to see them abandoning their profession. But there are people like Grant who don't. And I really do encourage people to try to find independent pharmacies. And I'm not being paid by the Independent Pharmacy Association. That's just been my experience for 40 years. I mean, no matter where I've practiced, I've always found one or two independent pharmacies to work with because they know drugs. Doctors don't know drugs as well as pharmacists. So, I rely on the pharmacist to call up and say, hey, I got a better idea here, or, I think that's a little too much, or whatever. So pharmacists can be a big help, and people don't realize that pharmacists are willing to talk to people, and this occurs mainly in independent pharmacies. So go ahead, Grant.
My final thought. As much as each of us know, we have to stop and recognize that all the decisions that people make just about are exclusively made with emotion.
Mm-hmm.
So we have to be smart. We have to open dialogue. We have to open people's attitudes and their approaches to the things that are going on. And then we have to remember, as much information as we can bombard people with, emotion is going to be what makes the final answer. So we have to be able to recognize that and play to an emotional factor in a small way, no matter what.
Hear, hear.
Absolutely. Well, Grant, thank you so much for joining us this evening on the Doctor's Corner. And I hope you have a great
Thank you for having me.
Yep, thank you. Well, Dr. Kline, thank you as well. And a big thank you to our audience for taking some time out of your evening to join us here at the Doctor's Corner. I'm Janelle Elgaway with Dr. Kline, signing off until next Tuesday. Have a great night, everyone.
Good night.
This has been The Doctor's Corner with Dr. Kline and Janelle Elgaway. Copyright 2018. All rights reserved.